Next, let's look at a setup with the suction hooking, in alignment parallel to the tooth axis. We'll begin with tooth number 24's occlusal. The patient's head turns left, and the operator, positioned at 10 o'clock, aligns parallel to the tooth axis. The waist is within a stable range, and the neck has a slight forward flexion to secure the field of vision of the maxillary occlusal surface. The suction is placed on the left side. The now free left hand employs its fourth and fifth fingers to rest close to the left zygoma, while the first and second fingers are used to lift the obturgate, preventing water splashes. The third finger offers supplementary support to the handpiece head. Meanwhile, the right hand uses its fourth finger to brace itself on the mentum. Now, here's something to think about. Regarding the secondary curve of the mounted suction tip, would an inward or an outward curve be more ideal? If you've been following the lecture closely, you should be able to figure out for yourself that an inward secondary curve is better. The reason for this particular bending of the suction is so that its volume can create an S-curve that extends more toward the mandibular direction. This ensures that the space is not obstructed when the handpiece head is moved toward the occlusal surface. As I've said repeatedly, if you approach the occlusal of the maxillary posterior teeth in parallel mode, the forward flexion of your neck increases significantly. This, therefore, puts considerable strain on the neck, so approaching with a perpendicular alignment is significantly better from the perspective of a pain-free posture. In the suction grasping mode, both hands are holding instruments, which restricts your choices. However, in the suction hooking mode, as demonstrated now, there is a significant benefit. The benefit is that by not grasping the suction, your left hand is freed up to hold a mirror, allowing you to utilize an indirect view with the mirror at opportune moments as needed. Especially for cavity treatment on maxillary posterior teeth, I often use hooking combined with parallel alignment and an indirect view using a mirror. This is because through the use of a mirror view, you can prevent the development of a forward flexion posture in your neck. When performing an indirect view with a mirror, there's another point to be aware of. The rule I always emphasize, that the closer the operator's body is to the patient's head, the better, does not apply in this specific situation. It's an exception. When employing a mirror for an indirect view, it is actually more harmonious to maintain a certain amount of distance. There are some instances where increasing this distance between the dental professional and the patient's head is actually more beneficial. One is accessing the lingual of the mandibular anterior teeth with parallel alignment, and the other is accessing the palatal of the posterior teeth with perpendicular alignment. We will have an opportunity to delve into this more extensively in an upcoming lecture. The core criteria for determining whether to bend the secondary curve of the suction tip inward or outward, as previously noted, stem from the fundamental principles introduced at the very start of this lecture. Visibility, can you see clearly? Information, can you clearly obtain the necessary information? Accessibility, can various surgical instruments access and contact the area effectively? And protection. Are the soft and hard tissues around the target area that need to be protected well protected? These three principles are the fundamental basis, and I've personally added one more: pain-free posturology. Whether the posture puts undue strain on the musculoskeletal system can be another criterion. Let us now look at the preparation of the buccal, mesial, and distal proximal surfaces. To improve buccal visibility, rotate the patient's head right. The operator is at about 130, aligned parallel to the tooth axis. The waist and neck maintain their healthy range. The suction is held on the right side, allowing the left hand, now free, to assist in securing the visual field of the proximal surface, particularly the distal aspect, through mirror retraction. The right hand rests the fourth finger on the anterior teeth. One important point to consider here is that if you've retracted the commissure with the suction tip in suction grasping mode without actively suctioning, in the hooking mode, where the suction is hooked onto something, you perform retraction of the commissure using the mirror neck. Because the mirror neck is considerably smaller in volume compared to the suction tube, it is much more beneficial to use the mirror for retraction when preparing a patient who has strong tension in the commissure area. This is because you can pull with less force and cause less discomfort. Additionally, as you progress from the premolars towards the inner molars, the necessary commissure retraction for securing the field of vision becomes greater. Therefore, in the molar region, it is particularly beneficial to grasp the mirror in hooking mode rather than grasping mode for retraction. Let's look at the prep for the palatal side and the mesial and distal proximal surfaces. Patient's head turns left. Operator at 10:30. Suction is on the left. The right hand's fourth and fifth fingers rest on the right masseter, and the handpiece is held with a long grip. The fourth and fifth fingers of the left hand rest on the patient's right zygoma, while the third finger offers additional support to the handpiece head. Because a long grip sometimes tends to reduce stability, it is generally recommended to use your free, opposite hand to provide supplementary support. What I want to emphasize on this slide is that even though I've classified this as a parallel alignment category for organizational purposes, the 10:30 position is not, strictly speaking, a true parallel alignment. However, you should understand it as being very close to what can be described as a complete parallel alignment, essentially existing somewhere in that intermediate zone between a completely parallel and a perfectly perpendicular alignment. However, even if your body isn't in perfect parallel alignment, you can still achieve parallel alignment between your line of sight and the tooth axis by applying a slight lateral flexion to the right in your neck in this 10:30 position. Next, let's change the alignment mode and look at a perpendicular mode rather than parallel to the tooth axis. In the perpendicular alignment with the suction in a grasping mode, let's look at the occlusal target area on tooth number 24. The patient's head should be rotated slightly to the right. The operator is positioned at 9 o'clock and aligns their body in a way that is almost perpendicular to the tooth axis of number 24. When doing an occlusal prep from the palatal direction, rest your right fourth finger near the right masseter area. With your left hand, rest your fourth and fifth fingers on the left zygoma and use the suction tube to slightly retract the commissure. At times, occlusal preparation is performed from the palatal aspect. As you'll observe, for occlusal preparation from the buccal aspect, the hand position and overall stance are adjusted. When performing an occlusal preparation from the buccal aspect, you should interchange the positions of your right and left hands, as I'm demonstrating once more. Utilize the left suction tip to safeguard the tongue, while your right hand should rest on the mentum as you direct the handpiece toward the intended area. Let's review this again. Prep from the palatal side. Switching hands, prep the occlusal from the buccal side. The left image illustrates the two-handed positioning for occlusal preparation when approaching from the palatal aspect, and the right image displays the two-handed posture for occlusal preparation from the buccal aspect. There's a distinction. When approaching from the palatal aspect, the handpiece entry angle is more inclined and nearly horizontal to the plane created by the oral cavity. Yet, when approaching from the buccal aspect, the handpiece entry angle becomes almost perpendicular to the oral orifice's plane. This is a natural difference that arises when you try to approach the target area of the tooth with the handpiece head in perpendicular alignment mode, while simultaneously maintaining a rest. Another notable point is that the bending of the wrist can either be within a healthy range or extend beyond it, depending on how the higher level posture elements are set up. Observing the red line on the left hand, when the approach is made from the palatal aspect, the wrist exhibits a comparatively significant degree of flexion. Conversely, when approaching from the buccal aspect, the left wrist remains in a relatively more straightened position. So, what methods can the operator use to alleviate the left wrist's bend into a healthier position? The solution is to modify the higher level posture elements according to the principles I've mentioned several times. You could also apply slightly more leftward rotation to the patient's head, or the operator might shift their body a bit further in a clockwise direction. By doing so, the bend in the left wrist can be brought into a more stable range. However, here is where a trade-off comes into play. This creates a disadvantage in securing the field of vision of the occlusal surface, so to compensate, the operator's neck inevitably goes into flexion. Thus, in the two-handed dentistry we currently practice, where we mainly utilize a direct view, it's not always feasible for every posture element to stay within the optimal healthy range we aim for. However, if one can be self-aware of how posture elements are coordinated, understanding which specific posture elements, such as the arms, wrists, or neck, fall outside the healthy range, and which ones, like the torso or waist, remain within it, then through various applications and modifications of posture, it would be possible to prevent strain from accumulating on a single part of the body. The top photo shows posture when approaching the occlusal surface from the palatal side and the bottom from the buccal side. In this slide, let's focus on the height of the shoulder and the right elbow among the various posture elements. In the picture at the top, the shoulders appear parallel, and the right elbow is at a suitable height. In the lower picture, the right shoulder is elevated, and the right elbow is also positioned higher than the left one. One reason for this is that the operator's body is positioned at approximately the 8:30 mark, necessitating the right elbow to elevate above the patient's body to prevent any unintended contact. One effective strategy to mitigate such postural imbalances is to manipulate the height disparity between the dental chair and the stool. This can be achieved by either lowering the chair's elevation or increasing the stool's height, ensuring that even when the operator is positioned at the 8:30 mark, their right shoulder and elbow do not become excessively elevated, thereby promoting a more ergonomic working posture. Next, let's examine the palatal, mesial, and distal proximal surfaces. To secure the palatal view, the head is turned left. All other posture elements remain identical to the previous ones, shown transparently here. Let's proceed by watching the video. Like so. Prep the palatal, mesial, and distal surfaces. When working on the palatal surface of tooth 24, the right hand holding the handpiece can utilize either a long grip or a short grip, depending on the need. The left photo shows a long grip with the fourth finger resting on the right masseter. This specific arrangement offers the benefit of lessening the likelihood that the hand's volume could impede the visibility of the oral cavity. The right photo shows a short grip with the fourth finger resting on the upper premolar. This configuration offers a more stable rest on the hard tissues, which intrinsically ensures greater steadiness in handpiece movements. The benefit is increased stability, yet the drawback is that the hand may potentially obstruct the field of vision. Personally, I opt for a long grip and provide additional support to the handpiece head by using a section of my left hand, specifically my second or third finger, as a secondary brace. Now, the only remaining task is the preparation of the buccal, mesial, and distal aspects from the buccal side, as well as the occlusal target areas, all in the perpendicular R mode. However, in this particular case, I will not be covering the posture that corresponds to the perpendicular right. Using a perpendicular right alignment to prep these regions is often uncomfortable and not advisable for several reasons. Therefore, it is abundantly clear that employing either a parallel or perpendicular L alignment mode would be much more appropriate in this situation.